Good morning, everyone. We want to use the time efficiently today, so we will start. Our speakers will be plenty, and we want to use our time efficiently. Zehra Kabakçı is our first speaker. Hello, I'm Assistant Dr. Zehra. I will be talking about the disuse of methamphetamine and focusing on minor physical abnormalities and methamphetamine-induced psychosis. I'll start with the background. As you know, because of its psychosis activities, 40% of all users may have affected, but methamphetamine basis is not persistent or consistent in that regard. In that regard, having a psychosis history in the family or other risk factors are detriment in this. Anomalies in terms of cosmetic look may seem much less apparent, but in first and second one, in morphogenetic analytical cases, we see differences. In central nervous system, again, with the ectodermis base, we see ketonosis. MPAs may give us knowledge in this topic or even help us in the research towards development of susceptibility of schizophrenia and psychotic disorders. In this regard, between MPAs and MIP and methamphetamine use disorders, we investigated the interconnectedness. Some preliminaries here, and we had 19 patients diagnosed with MUD and misuse of methamphetamine and 29 patients diagnosed with MIP in total. And we focused on these. We had Hamilton Depression Rating, Hamilton Anxiety, Profile Index, SAPS and SANS were also used in measurements. We used a modified Waldrop and Pace scale for measurements by me and my friend, and we had focused on inter-rater reliability first, and we had a questionnaire with yes and no's, but some of them were also measurable values. This modified Waldrop scale had 19 questions, but in other studies, we see spindle ear and strabismus were also used, so we also included in our scales and measurements. In results, then we had two groups with sociodemographic values, substance and use characteristics, and HAM A and HAM D scores were no different significantly, but MPA items were analyzed individually. Sandal gaps, low-seated ears, and intercardinal distance in psychosis group were substantially higher. Again, we had written yes or no in our questionnaire, but also had measurable data saying 0.5 or 0.7 or the sandal gap, the length between two toes, and had written that as the distance being, say, 0.5 or 0.7, and intercardinal, the length between two eyes or the ears were also some of the substantial findings we had. However, in total MPA in the entire scale, we see psychosis group had a higher average and in total MPA score, and SAPS SANS scores were in total coloration. MPA scores increasing resulted in SAPS or SNES scores increase. I believe our study in methamphetamine group is the first study. In terms of schizophrenia, MPA and schizophrenia relation have been well documented in the literature. In 2014, there has been a study with similar topics to ours where they have seen sandal gaps, low drop ears, and others. But I wish to say that significant differences were found in various studies. In a study that investigated the relationship between MPAs and clinical features in patients with schizophrenia spectrum disorders with the PANSS and Waldrop scale, correlation was also apparent and negative symptoms were observed. And clinical globular CGI scores were the starting age, the first date of hospitalization were also some of the color-rated data, where we see increase in MPA results in more hospitalizations and a younger age in hospitalizations. So in terms of psychotic signs, it is in accordance with the studies and the literature, but MPA and the use of psychosis, and it's preliminary for schizophrenia, or can this be identified as a biomarker? Further study is needed. Hopefully, once our study is concluded, it will be a stepping stone in the literature. Thank you. Thank you. Do we have any questions from the audience, perhaps? Okay. It was a valuable study in terms of methamphetamine and its correlation with anomalies, and your sample size, perhaps you said 19 and 29 in two groups, perhaps a larger sample group and a better processing could be an expansion to your study. Thank you. We wanted 73 in total, but uh, there was a small, uh, let's say, attendance that had methamphetamine use, but no case of psychosis. You said it's a difficult sample to get to begin with, but it was a very valuable research. Thank you. Any questions or contributions? Otherwise, thank you. And Sinem Çetin Demirtaş is our second speaker. Good day and good morning, everyone. I'm Sinan Çetin Demirtaş. I'm from 5 Ocak State Hospital. I will be focusing on medical students today and the relationship between social media use, psychological well-being, and quality of life in them. This doesn't move, but okay. Thank you. Okay. Firstly, in our study, we focused on the literature first because it's a common topic, but we focused on additional topics like quality of life and the active use of social media in the youth, because this is not just related to medical students, but as a social aid, we can consider social media as an active presence in every cycle of life. In recent times, especially, attention span and quality of life has also been, in relation to social media usage, have been impacted. We aimed to examine the relationship between social media addiction, psychological well-being, quality of life, and academic achievement among the students, and see good and bad that came out of it. We focused on Çukurova University, on 84 medical students aged 18 to 25. Exclusion criteria was have not having an active psychiatric disorder and not using social media. When we examined the students, if they had no apparent symptoms or no descriptions of a disorder, but inactive treatment for any disorder, potential disorder, they're also included. We had Pittsburgh Sleep Quality Index, Bergen Social Media Addiction Scale, and lastly, included internship achievement scores for our analysis, independent groups, Pearson correlation test, and multiple regression analysis were conducted in the data. In the multiple regression analysis, you will notice that the sleep quality index and its measurement Indirect correlation will show us how data reflects on other aspects, and they were included. We have seen a significant apparent negative relationship between scores and social media addiction. In detail and subscales, we see psychological and physical well-being were also in relation. In addition, social media addiction was also negatively associated with environmental domain in recognition. In other subcategories, we have also seen regression models were found in well-being and social media addiction, and specifically on female students, we had higher internship scores overall compared to male students, irregardless of other values. As for the discussion side of things, we see social media addiction normally or in literature as expected is a direct influence in the decrease of quality of life overall. And in addition, I'm sorry, oh, one thing was missing here, especially in academic success in female patients, we see academic organizations structure or motivation might be an additional cause in their measure in quality scores. Also, in academic achievement does seem to be in direct relation to quality of life also. Social media addiction significantly reduces the psychological dimensions of quality of life. The results we found are not additionally divergent from the literature. Aside from the environmental factors, it was pretty much on point with the existing studies. We see young people, adolescent teens, and children with their depressive or psychological complaints. The measurements show that perhaps students could be supplemented in their clinical evaluations, that social media could be included in additional media. Our conclusion and also one of our targets and perhaps a future research would be to include social media in therapeutic or in clinical assessment of younger patients, and perhaps a lesson could be given to them to how to balance out the real life and the social media. The literature was consistent with our findings. Lastly, maintaining academic and psychological functioning requires establishing a healthy balance with the digital life, is our last word. It is impossible to remove it completely from our life. It won't be realistic either. But healthier the integration, but for children and adolescents and others, I believe it will be a healthy addition in recovery. Thank you. Thank you, Sinem. Any questions or contributions? Okay. Thank you. Thank you for being here, Gizem. Medical students, I mean, in the Turkish sample we see here, it was a valuable output you've given. And in the next steps, I hope your projects and studies will continue. Our third speaker is Sara Sedat Abazork. I'm sorry if I'm mispronouncing it. Are you here? Okay. Then we'll move on with the other speaker, İknur Kiraz Arcı. Not here either. Fifth speaker, Merve Ceylan Çörek, is here. Good morning, everyone. I'm from Erzurum State Hospital. I'm Merve. Depression is a syndrome characterized as sadness, sometimes both sadness and anxiousness, And it affects our thought, speech, movement, appearance, showing them as slowing down, stagnating, and gives the feeling of worthlessness, weakness, moodiness, and pessimism as a definition. And increasing evidence suggests that inflammatory cytokines contribute to development of depression in both medically ill and healthy individuals. Chronic exposure to high levels of inflammatory cytokines and permanent changes in the neurotransmitter system can lead to neuropsychiatric diseases and depression. ECT is one of the most effective treatment strategies for depression, demonstrating superior efficiency compared to antidepressant medications in numerous studies already. ECT, although it is used in many diseases, its mechanism is not fully recognized, known. However, recent animal studies show that electroconvulsive seizures cause structural changes in the cellular molecular levels of the brain, particularly in animals and humans. We see the ECT that is applied change the neuropeptide and immune signal mechanism in both the central nervous system and the peripheral tissues. Post-ECT shows that increased cytokine mobilization in the peripheral blood, such as increased levels of TNF-alpha and IL-6, is a common immunological finding. Acute ECT patients with major depressive disorders also makes peripheral blood monocytes more sensitive to stimuli that cause their proliferation, resulting in increased secretion of TNF-A and IL-6. In depressed patients, the recent studies shows that inflammatory cytokine highlights in TNF-alpha is on a decrease, and this is one promising result. Examining the effects of ECT on inflammatory markers that play a role in the pathogenesis and of depression may help clarify the etiology of depression and understand the mechanism of action of ECT. In this context, then, we aim to compare the level of inflammation markers on patients diagnosed with depressive disorders who received ECT and are healthy volunteers. In Atatürk University Psychological Studies, we had unipolar depressed patients with ECT application, 26 patients, and other 26 healthy volunteers were used in the testing group. We have tested histories of cognitive, psychiatric, neurological, genetic, endocrinological, and more. All participants filled out a form. MUD-ARS was completed by the clinicians before ECT, and the ECT's results were also conducted post-ECT. All attendees were measured in procalcitonin PRC, IL-6, IL-8, TNF-alpha, homocysteine, CRP, erythrocyte, sedimentation rate, and neutrophil lymphocyte ratio, NLR. We see the parameters set pre and post ECT with the MAD-R score. We performed this on gender basis, and we see that the negative correlation was found significantly higher in women and not in men. Depression patients' NLR was higher than healthy controls in all measurements. PRC and homocysteine levels were high before or during the ECT, and they returned to same levels as healthy controls post-treatment. TNF-alpha was the same level in depressed patients before and during ECT with healthy controls, but it was lower post-treatments compared to healthy controls. In addition, IL-6 levels in depressed patients were found to be lower than healthy control group, while IL-8 levels were found to be higher than the healthy control group. Before ECT, lower levels of TNF-alpha was found to be a predictor of clinical improvement on women, and I believe in future studies with much more sample groups, TNF-alpha in major depression and pathogenesis, we believe its impact mechanism and supplementary, and also for much more modalities with patients with severe MDD, this will be a significant step in the treatment. Thank you. Thank you. Miss Merve, do we have any questions or contributions? Okay. Thank you. Okay. Our sixth speaker, Ayse ERGÜNER. Sorry. Major depressive disorder is a prevalent psychiatric disorder that significantly impacts individual quality of life and is strongly associated with increased risk of suicide. We see suicide is the 10th leading cause of death worldwide, and with MDD, we see 25% of individuals had prior contact with mental health services and suicide attempts. Traumatic losses, gender, psychiatric hospitalizations, history of psychotherapy, and the frequency of suicide attempts are in correlation. We see such factors in cases with MDD. We wanted to focus on the correlation between all of them. We want to focus on a history of sexual abuse, traumatic losses, gender, past psychiatric hospitalizations, and psychotherapy, where we had 277 women with such histories were in the study, and it has shown that thoughts of suicide and their correlation with accessibility to treatment was also under observation. And we've seen that earlier the age of trauma, the higher the attempt and thoughts of suicide have emerged in patients. Sorry. In our study, then, we focused on Izmir State Hospital. I'm also MD there. We went with HDRS with 60 inpatients aged between 18 and 65. We had a socio-demographic clinical form. We focused on things such as history of sexual abuse, traumatic losses, past hospitalizations and psychotherapy history, suicide attempts, and clinical data. And their Hamilton depressive rating scales were compared in their first admission up until the end of their admission. In the first graph, we can see in the statistical analysis that people with more than one attempt was 36, and we see the graph here with less than two, and we see the sexual abuse history has been a differentiating point in the scales. People with past suicide attempts and their correlation with history of sexual abuse, the frequency of abuse and attempts have been in correlation. We see in the graph here, especially in the red, with sexual abuse history and more than one suicide attempt at least. It was the most prevalent. Suicidal tendencies and gender and sexual abuse story was also in correlation. And we can see the results that psychotherapy history in patients with clinical history had a higher ratio in attempt, and there was a correlation between also in suicide attempts and the tendency of sexual abuse. We see women in particular have been more towards attempt compared to men in the graph on the left. The traumatic losses correlation with suicide attempt and hospitalization. Traumatic loss significantly has increased the thoughts and attempts of suicide. We see also people's psychiatric ratio also increase the suicide attempt, and we can see that on the graph on the right. Again, suicidal tendencies and psychotherapeutic histories shown in HRS score comparisons here. Suicide attempts and psychotherapy history in terms of depression point have shown to be differentiating. With more than one attempt, people, the HRS scores were higher, as you can see the yellow on the left graph. In our patients with past therapy, we can see no therapy shows us a higher percentage in suicide attempts. In discussions, we can see that in the literature, as it is known, thoughts of suicide and attempts of suicide increase the risk of suicide in general. And in our study, we focused on depression symptoms have also contributing to such factoids of suicide. In terms of gender, we see most study uh, many research that put men and women in a higher ratio or equals, but not specifically comparing both genders and segregating them on a joint study. But it seems to study that there might be a potential increase where gender plays a part, and we see psychotherapeutic intervention is also as a diagnosis mechanism that decrease the attempts and thoughts of suicide. One thing we want to emphasize that sexual abuse history and suicide attempts have been correlated with more than one attempt. I've also read one meta-analysis and that long-term suicide risk is much more prevalent in sexual abuse during childhood, and seeing this childhood level trauma become much more prevalent in women compared to men emphasize the importance of security necessary for children and families. In past research, we know that summer is a factor that increases the suicide attempt, and we see that the repentance of suicide is also a factor to look into it here. And what we want to focus on that in bed patients in terms of psychological treatment have to be evaluated carefully with many factoids and historical evidence they may present, and a larger scale research should be conducted in such a manners. Thank you.
Yeah, any questions or contributions, comments? May I ask a question? This traumatic losses, social demographic data, how did you ask it? This is a retrospective scanning and for patients with major depression and pathological grief. Pathological grief diagnosis and those who are not diagnosed with pathological grief. Clinical observation, those with grief and not with grief. For the diagnosis of traumatic loss, pathological grief. For the integration of psychotherapeutic sessions to the treatment. Thank you. Thank you. Any other contributions, comments? No, thank you. Next speaker is Didem, Sule, Erdem.
Buyurun Didem Hanım. Herkese merhaba. Ben Didem Şule Erdem. Başakşehir Çamsakura Şehir Hastanesi Psikiyatri.
Didem, Sule, Erdem. I'm working in psychiatric department of hospital in Istanbul. Today, I will be telling you about serum neuropeptide Y levels in medication-free patients with major depression and relationship with gender. Depression is a significant public health issue that is increasing prevalence, high rates of chronicity and relapse. The studies for neuropeptide Y is a neuropeptide studied in relation to depression, and it relates to nutrition, blood pressure, emotion, stress, and impulsivity. And for the depression patients' neuropeptide levels, and we aim to study this. And in conducting this, when we scanned the literature, mostly the medicated patients are mostly studied, and we prefer the medication-free group of patients. There were 69 MDD patients, and 48 were female and 21 were male, and age was from 18 to 65, and drug-free at least for 2 weeks, and for 6 weeks, fluoxetine, subtypes, neurological, metabolic, endocrine diseases, exclusion criteria, other psychiatric disorders, psychotropic medication use, substance use, and control group. There were 30 healthy volunteers, 19 female and 11 male, same age range and criteria as patients. These were control group. Ethical board approval by RGS University. This project was supported by TÜBİTAK, and we have conducted the clinical interview, and we used Hamilton scale and the fasting blood samples and serum stored at -70 Celsius degrees, and we have used SPSS and Anormalities Shaffer-Wilk test and Mann-Whitney, ANCOA, and Square and Spearman's correlation tests were applied. The findings were as follows. Hamilton scores were significantly higher in the patient group, and neuropeptide Y levels were, there was not significant difference, neuropeptide Y difference in the gender or sexes. Female women had higher than male, and total disease peer illness duration was higher for women, and there was positive correlation with neuropeptide Y. And as I said, no significant difference was found within neuropeptide Y levels, but it was higher in female patients than males, and literature shows conflicting findings. There were similar studies. Some studies reported no significant difference between patient controls. Other funds altered, and these discrepancies may relate to pharmacological treatment status, depression subtypes, changes in sleeps and appetite, patients not being in an acute episodes. One study noted that antidepressants can elevate NPY level, and use of antidepressant has impacts on NPY levels. Therefore, as our patients were not taking any medication, this increased the accuracy. A meta-analysis, recent meta-analysis had similar findings. When we look at other meta-analysis, lower peripheral blood NPY in depressive patients, and this was studied, but the number of neuropeptide Y level, it was higher in females than male. There was positive correlation similar to our findings. And this shows that neuropeptide Y could be relating to chronic stress, and chronic stress and total illness period, the neuropeptide levels could increase. And conclusion, NPY levels may be associated with the total disease duration. Female patients showed higher NPY levels, and these findings point at the potential role of NPI in the neurobiology of depression, further longitudinal. And of course, more longitudinal studies with larger sample sizes are needed to better understand this relationship. Thank you, everyone. Over. Any questions or contributions? If I may pose a question. It was 48 female and 21 male. Maybe was the sample demographics had an impact? It's an ongoing study. No, this was finalized. That was also our question in mind. Similar studies had same sample demographics, and depression is more widespread and common among females. This was also... Thank you for taking your time and presenting your findings here. Last speaker is Ai Chun Chan. I think the speaker is not in the room. Okay, thank you.